Good morning, everyone. My paper for today is on traumatic and LDO clinical profile and management outcomes. So we know trauma is an important cause, secondary cause for acquired lacrimal drainage obstruction, and the causes could be iatrogenic or non-iatrogenic. Iatrogenic causes include aggressive lacrimal probing or sinonasal procedures. Non-iatrogenic causes include midfacial fractures. So there's always an associated facial deformities and altered bony anatomy, which makes the management very challenging. Thus, here we aim to highlight the clinical profile, management, and surgical outcomes in patients diagnosed with traumatic and LDO in a tertiary care center. So it was a retrospective interventional study done during January 2014 to December 2024. Detailed history, including the duration of symptoms, pattern of injury, mode of injury, etc., was analyzed. We included all patients with persistent traumatic epiphora with the diagnosis of NLDO and excluded cases with primary acquired nasal lacrimal duct obstruction and canalicular obstruction and iatrogenic causes. Thorough lacrimal system evaluation to assess the tear meniscus height, position, and appearance of puncture annulets. Roplas was done in all patients. Irrigation of lacrimal system was done. CT orbit was performed in all the patients, and when the diagnosis of traumatic NLDO was made. So all the patients underwent surgical interventions in the form of external DCR with single flap anastomosis with silicone intubation. And post-operatively, all the patients were prescribed topical antibiotic steroid combination eye drops in tapering doses for 4 weeks, augmented with systemic oral antibiotics and nasal decongestants. The silicone tubes were removed after 3 weeks. The follow-up on day 1, first week, 4th week, 3rd and 6th month, and then yearly. At every visit, the symptoms were analyzed, surgical site was examined, and lacrimal evaluation was performed. Our success of surgery was measured anatomically by the patency of the new ostium and functionally the complete cessation of symptoms. Results, our study included 20 patients, 90% were male, 10% was female. Mean age of presentation was 36 years old. Mode of injury was RTA in 19 patients. Most common pattern of injury was naso-orbitoethmoid fracture, which is 60%, and 15 patients had history of previous maxillofacial fracture repair. The most common associated ocular signs was telecanthus seen in 30%. Most common presenting complaint was watering. Roplas was positive in 14 patients. So we did CT scan of all the patients. A repeat CT was done in 11 patients to assess the position of screws and plates. All 20 patients underwent external DCR with silicone intubation, under GA in 14 patients and under local anesthesia in 6 patients. The surgical duration averaged for around 60 minutes. The average follow-up period was 17 months. So the discussion in our study, majority of patients were males involved in RTA. The predominant injury was naso-orbitoethmoid fracture. So as the nasolacrimal duct is present in the lateral part of the nose, so any NOE complex injury can result in an obstruction. So the NOE fracture is any fracture involving 4 out of 5 components. That is the fracture of either medial orbital wall, inferior orbital rim, lateral nasal wall, nasomaxillary buttress, and frontal process of maxilla. Post-traumatic NLDO in the literature can be observed in 5 to 21% of NOE fractures. In contrast, in our series, around 60% had NOE fractures. So trauma to the lacrimal pathway can either cause a temporary or permanent dysfunction. So temporary is because of the post-traumatic edema, and permanent is because of the bony fracture and the altered anatomy, causing cicatricial changes. Telecanthus invariably accompanies severe NOE injuries. In our study, around 30 patients had telecanthus. Other features included were enophthalmos, ptosis, and blepharophimosis. So why imaging is important in traumatic NLDO is to assess the anatomical structures post-trauma to identify the presence of any screws or plates. So primary repair of maxillofacial and NOE injury should be performed earlier to avoid deformities to the nasolacrimal system. So once the diagnosis is made, thorough counseling regarding the clinical condition, need for surgical intervention, types of surgery, the anesthesia, related complication, and failure rates should be discussed with the patient. External DCR is still considered to be the most reliable technique, having a success rate of 90%. As reported by Besley et al. In a retrospective analysis, there was a 94% success rate in external DCR performed, and the silicone stents were removed after 3 months, but in our study, we removed after 3 weeks. So these were other studies where the success rate of more than 90% was seen. So a study by Adenis et al. Suggested that surgery should be performed 6 months post-trauma. And external DCR is still a gold standard, and why not endonasal is because of these challenges, that is extensive fibrosis, severe anatomical disruption, presence of screws and plates. So to avoid failure rates, what we employed was a larger incision. Orbicularis muscle was not cut. We performed a wider rhinostomy, application of mitomycin C, silicone intubation. So we had 100% success rate in our study, even though the surgical duration differed. And the success was measured by a patent lacrimal syringing test and a cessation of the symptoms. We had an average follow-up of 17 months. So to conclude, patient with permanent epiphora with trauma needs evaluation for traumatic NLDO, and reassessment after 1 to 3 months of initial trauma is mandatory. Preoperative imaging is mandatory, and careful assessment, including the level of obstruction, is very critical. External DCR provides an excellent surgical outcome in cases of traumatic NLDO. These are my references.
Nice presentation, but what I would suggest you in future when you present the study, please stick to the title of your study. Right? Your title suggests the epidemiological clinical profile and management outcomes. So your conclusion slides should have highlighted that. What was the clinical profile of such cases and what was the outcome? After that, your discussion comes, right? And when you say management outcomes in a study, it has to be quantified, either in form of primary outcome measures, secondary outcome measures. In your case, primary outcome measure, I think, is success rate. But again, success rate, you'll have to define. What do you mean by a success? Post DCR, right?
Yeah.
So if you reorganize your paper in those headings, then it will appear more attractive to the judges. Or otherwise, nice to be. Thank you.
Usually in our setup, we used to get a traumatic canalicular injuries more common. But
So
you have said
we
even in
excluded
previous
those.
other study also it is same. But your study you are telling 60% nasolacrimal duct.
60% had
You have taken any particular trauma or any all the trauma around the face.
all trauma.
In that
like
case,
RT.
canalicular injury is very common. For that, you have to
But
put
we
the water tank.
excluded those cases.
No, you excluded that.
Canalicular. Yeah.
Can-
Main highest
Highest,
pain. Yeah. Okay.
It's a sac injury
Yeah.
is always better. Good. Canalicular injury is very tough to manage.